Dear colleagues, first of all, I would like to thank the organizer for inviting me for such a very interesting symposium. My theme is application of Plethysmography in asthma and COPD diagnosis and treatment. Making right diagnosis is crucial in management of any disease. But in asthma and COPD, usually the doctors get a very confusing history. So it makes differential diagnosis between asthma and COPD become difficult. The application of spirometry and especially plethysmography with the new guideline of ATS and ERS 2021 can help us. I would like to remind you about this very important article of the ERS ATS technical standards on interpretive strategies for routine lung function tests. And it is some key points. The general comments of this article, they have more emphasis on using pulmonary function tests to classify physiology, but not make clinical diagnosis. Because if you would like to make a diagnosis, you must take a history and chest X-ray and something other one. And they emphasize on the uncertainty of interpretation, especially when the result is near of the lower limit of normal. For the reference equations, I think that it's very important because we should use now the GLI, the Global Lung Function reference equations for spirometry and lung volumes and also for DLCO. So in Vietnam, we have to change to the GLI reference with the Southeast Asian. Please take care, this very important part. And more emphasis on incomplete understanding of role of race, ethnicity, and lung function. But in our region, I think that our ethnicity is rather unique, so that we could use the Southeast Asian reference of the GLI. And they clarify that the biological sex, not gender, be used to interpret the lung function. It is the biological sex. For the normal range, we will use the lower limit of normal. It is the 5th percentile and upper limit of normal for the lung volume or for the DLCO, 95th percentile. And remember that even GO 2024 still use the ratio FEV1 over FVC less than 0.7, but with the GLI and also with ATS ERS, they are not recommended, but you have to use LLN also, lower limit of normal, for this ratio. And also, we will not use the 80% predicted to define normal, but use LLN. It's a very important one, and I think that with our new machine, we will have the LLN, the GLI, and the Southeast Asian reference. The bronchodilator response, it is also new. They recommend that we will use if the predicted values of FEV1 or FVC both minus than pre, greater than 10%, then we will have a positive bronchodilator test. But GINA 2024, it is a very important guideline in asthma. They still do not agree to use this new criteria. They use the old one. The choice of the protocol of administering bronchodilator not specified in this article. Interpretation of change over time. They have a conditional change score in children and FEV1Q in adults, but it is still not very widely applicable. And it is also a very important slide. Instead of use 80%, 60%, or 40% to classify mild, moderate, or severe, the ATS ERS suggests that for all measure, we use Z-score. The mild is minus 165 to minus 25. Moderate is 251 to minus 4, and severe if it is less than 4.1. And this morning, Professor Carr have shown to us that the severity of lung function impairment have a strong correlation with the mortality. So I think that it is a very strong recommendation, and I hope that we could use this one. For the classification of physiological impairment, the airflow obstruction, we will use FEV1 over FVC, less than 5th percentile. It is less than lower limit of normal. We could use FVC also. The FVC, for the lung volumes, we could detect hyperinflation or air trapping. Dysynapsis, it is also a new definition, and non-specific pattern or prism. And with the flow volume curve, we can also recognize the central or upper airway obstruction. The restriction, ATS and ERS emphasized that we could not define it by spirometry anymore. We have to go to the lung volume, and the best machine to measure lung volume is the plethysmography. The TLC, the total lung capacity, less than 5th percentile, and we will have the simple versus complex restriction. Dr. Carr have explained us this morning. We have a hyperinflation or air trapping and mix. Gas transfer impairment, we will use the diffusion capacity of the lung using the carbon monoxide, and if less than lower limit of normal. And we also have to use a VA, it is alveolar ventilation, and transfer coefficient, KCO, to classify low DLCO. And it is the lower limit of normal of 5%. It means that there will be 5% of normal person will be diagnosed as abnormal. But we have to accept it because we could not go all the way to find out zero normal person. It is the approach to interpretation of spirometry, and we have taught it many times this morning. And remember that we begin with the ratio FEV1 FVC and go by that way. If there is obstruction together with restriction, but remember that we could not decide restriction with this spirometry, so that we have to go to lung volumes. And if there is no obstruction and also no restriction, we have a normal spirometry. But if there is no restriction, no obstruction, but restriction, so we have to go to the lung volume. Thank you. For the interpretation of lung volumes, we will have the hyperinflation, large lungs, or normal lungs volume, or mixed disorder, or complex restriction. And we will follow this schema. And I think that we should have a copy of this interpretation of the LCO because it is rather complex to remember, and we have to define whether the LCO is low or high, and then remember that if there is a low, we always have to pay attention on the alveolar ventilation. So in the result of your test, you should have the alveolar ventilation. If you do not have this in this, you could not apply this interpretation. And then we go to the coefficient, transfer coefficient, KCO. And based on the result, we have 4 types. Loss of alveolar capillary structure, with loss of lung volume, we can see an emphysema of COPD or ILD, interstitial lung disease, or we have a localized loss of lung volume, for example, pneumonectomy, or incomplete lung expansion, a failure to take deep breath from patient, or neuromuscular dysfunction. Or we could have the pulmonary vascular abnormality, pulmonary hypertension, pulmonary embolism, vasculitis, or we have emphysema with preserved lung volume. It is early interstitial lung disease. Also early emphysema or anemia. But if we have a high DLCO greater than upper limit of normal, we have increase of blood flow, for example, left to right syndrome, and very important one is it will help us in differentiate from COPD and asthma. There is not a clear explanation about the high DLCO in asthma, but there is hypothesis that in asthma, the patient have more blood go to the alveolar obesity or erythrostosis or alveolar hemorrhage. So I think that those three classification approach to interpretation is very, very important. But the first one, you have to choose the right reference equation. For the Southeast Asian, we will use a GLI with Southeast Asian, and also you see that we will not use any percentage, but upper limit of normal or lower limit of normal. So now we will have some cases. The first one, it is 54 years old male, female with recurrent breathlessness, wheezing, cough for 1 year. The chest X-ray is normal, and we have the spirometric test for her. And you see that it is the result that we take from our UMC, University Medical Center, and you see that we use the reference values of GLI. So please remember, use it. GLI Conjure 2012. And for the ethnic group, we choose the Southeast Asian. And they also, the classification, the pre-test is A, post-test is A. It is that the quality is excellent. So you can check it right on the curve, or you just look at it. And we have pre-bronchodilator test and post-bronchodilator test and the change. And for the GLI, they do not use the slow vital capacity, so that you always have to use a forced vital capacity. In our UMC, we measure above, and we choose the bigger one. But if we use a GLI, they still do not have a Z-score for the slow vital capacity, so that we always have to use FEC. So we have seen here for the forced vital capacity, the Z-score is just 0.15, so it is normal. It is normal. And then for the ratio, we will choose the less one. So it is 67 and 65. We will choose the less one, 65. And then we compare with the lower limit of normal. It is less than lower limit of normal, so we have that obstruction. Sorry. For the severity of obstruction, we will see the Z-score of FE1. You remember that for the classification of the severity of obstruction, you will not use the ratio, but you have to use the FEV1. The FEV1 is minus 113, so it is normal. So we have a mild obstruction. And then for the post-bronchodilator test, you see that they have a very good bronchodilator test response. The patient do not have obstruction anymore. The ratio now is 0.76. It is bigger than lower limit of normal. So full reversible. For the change, you see that if we use the new criteria, you will use the post minus then the pre. The result is 13, bigger than 10. So the positive bronchodilator test. You could use also the FEV1, 116 minus 83. It is also bigger than 10. So, in result, we have the 54 years old female with the symptoms of asthma, and the spirometric test show us very clearly it is a typical asthma. She has obstruction, mild obstruction, but for post-bronchodilator test, there is no more obstruction, and there is a positive bronchodilator test. So with this, we confirm that this patient have asthma. If there is chest X-ray, and the history of patient is also confirmed that. With such a kind of typical of asthma, we do not need to go to the plethysmography. It is enough. And we have another one. It is 62 years old male, recurrent breathlessness with heavy smoking. And it is the same. We will look at the FVC. It is the rather old one, so we do not have the Z-score yet, but we could use the lower limit of normal. We could see that there is a restriction here. And for the ratio, we have the 56 compared with the 65. So there is obstruction. And it is a 55%, so we have a moderate obstruction. And the important one is the post-bronchodilator. We still have obstruction, 62 in comparison with 65. And there is the, for the bronchodilator test, we still have, we do not have the response if we use the new criteria. So there is obstruction with no bronchodilator test. And if you look at the flow volume curve, you have seen that it is very typical of the COPD with the very severe obstruction, and there is no response to the bronchodilator test. And with this, we still have to use the plethysmography because there is a small volume of the FVC. If you would like to confirm the restriction, you have to go to the plethysmography and to take a look at the TLC. The total lung capacity here is with normal Z-score. So there is no restriction. It is a very different conclusion if you go only by spirometric test. You see restriction, but on plethysmography, there is no restriction. So the conclusion, there will be no restriction. But there is an increase of the residual volume with the Z-score up to 410, and also the ratio RV and TLC. So we have air trapping here or hyperinflation. But I do not want to use the word hyperinflation. It is air trapping. Because if hyperinflation, there must be an increase of TLC. Yeah? And for the DLCO, it is also very important in this patient, because if the COPD patient with airway obstruction, in combination with reduced diffusion capacity of the lung, the prognosis will be very poor. And we see here the DLCO. Remember that when you measure DLCO, you always have to measure the hemoglobin first, because the hemoglobin will affect strongly on the result, so that we will read the result of DLCO with hemoglobin. And there is abnormal, moderate decrease. And for the transfer cooperation coefficient, we have also reduced. And VA, we have also reduced VA. So we take a look at the table, and you see that we have a abnormally low DLCO, also low VA, and also low KCO. So we have the result that this patient have loss of alveolar capillary structure with loss of lung volume. It means that he has emphysema. And because the chest X-ray do not show any criteria for ILD, and they are smoker, so we come to the conclusion that this patient have a COPD with airway obstruction and also decreased diffusion capacity of the lungs. The prognosis of this patient will be very poor. So you can see that the role of plethysmography is very important, not only in the confirmation of the restriction, but also for the DLCO, a very important criteria. And we have another 70-year-old male. He has history of asthma, but smoking. So it is very confusing. We will not know whether he has asthma or he has a COPD, because just only 20% of the smoker becomes COPD. So before these patients, we have to decide whether they have asthma or they have COPD or they have COPD plus asthma. Former we call it ACO, but now we have a COPD plus asthma. And so we take a look at that, and the FVC is just at the limit. And the ratio is just 50 in comparison with 67. So he has obstruction. And for the severity, we look at the FEV1, and it is 2 minus 294. It is the obstruction of a moderate severity, moderate obstruction. And for the post-bronchodilator test, we see that the ratio is still less than lower limit of normal, just 53 in comparison with 67. And so they still have obstruction. And if you look at the bronchodilator test, we see that the 82 minus 273, so it is just 9. It is no bronchodilator test response. And for the FEV1, 55 and 46, also 9. So there is a airway obstruction, moderate airway obstruction, and no positive bronchodilator test, a negative bronchodilator test. But the problems, if you use the all criteria, you see that there is a positive. There is a positive bronchodilator test, positive bronchodilator test. So it will be very confusing for us. Is that patient has asthma, but he has smoking, he has obstruction, but based on all criteria, he has a positive bronchodilator test. So we have to decide asthma or COPD, or asthma with fixed airway obstruction or COPD. It's a very important question, because the way of treatment of asthma and COPD is very different. With asthma, we have to reduce the dose every 3 months. But for COPD, we have to escalate all of the time. And also the prognosis is very, very important, so that we have to go to the next step. It is the plethysmography. So I would like to emphasize that to make diagnosis of asthma COPD, you have to go to the box plethysmography. So we see that the TLC is normal. So he has no restriction. And, but there is the air trapping there. So the air trapping, it suggests the COPD. And the most important one is the DLCO. The DLCO is low. It's low, moderate decrease. But the key CO is normal, but the alveolar ventilation is low. So we will back to the schema to look at. So we have here low DLCO, normal key CO, but low VA. So low DLCO by that way, low VA, but key CO, low or normal. So it is also this patient have a loss of alveolar capillary structure with loss of lung volume. So what will you decide? Asthma with fixed airway obstruction, or COPD, or COPD plus asthma? Yeah, could you get that answer? Yes, it's right. Because we have seen the COPD picture very clearly with airway obstruction, with the loss of alveolar capillary structure. But remember that he has history of asthma. Yes, once the patient have history of asthma, you always have the diagnosis of COPD plus asthma. It's a very important problem because with this patient, you must have give them inhaled corticosteroid as asthma. In other way, they will have asthma exacerbation. So remember that in Vietnam, in our Vietnam guideline, we use this Spanish diagnosis. So we have this picture of COPD, but they have a current asthma diagnosis or even history of asthma, or they have the strong bronchodilator test response, or eosinophil blood count more than 300 cells per microliter. So we will have echo. So we have the asthma, COPD, and now echo. We have 3 types, and all of them have to base on the plethysmography. And we have the next slide. The 54-year-old male, smoking, heavy smoking, 25 pack years, dyspnea, cough, sputum, wheezing. And also, I think that we have now very familiar with this interpretation. We have restriction, but remember that we just say that possible restriction, yeah? Because we have to go to box to confirm that. And then with this one, they are higher than the lower limit of normal, so that there is no obstruction. And the bronchodilator test, here 77 and 70, no, it is 10 also. So we have the possible restriction, no obstruction, negative bronchodilator test. And we use this because we would like to explain the prism. The PRISM is a new term. It means that preserve ratio. So the ratio is normal, but impaired spirometry. It means that FEV1 is lower than normal. It is also, they would like go on suggest that we have to follow up this patient, because in the future they will may develop airflow obstruction. In all the time, we will explain, we will use it as a restriction, mild restriction, yeah? Mild restriction. But now we have to use the term PRISM, and also have to follow up this patient because they can develop obstruction in the future. And also with this one, we will have the normal TLC, so that there is no restriction. So remember that restriction have to base on the box, not on the spirometric test. And there is also air trapping there. So it is potential obstruction. We cannot see on the spirometric test. We just see normal, no obstruction. But by the box, we have just opposite conclusion. On the spirometric test, we conclude that there is restriction, there is no obstruction, but by the box, we have the opposite one. There is no restriction, but possible obstruction, because we have a mild air trapping right now. So I think that there is a very specific way to determine the result of a spirometric test, and we have to do the box to confirm. So once the spirometric test is abnormal, we have to go directly, right away, to body box. But in Vietnam, because of the lack of equipment or because of the cost, I think that most of pulmonologists just stop at the spirometric test. And you have seen that it is not enough. And the box will be paid, have been paid by the insurance, so that please do use it. Now, I would like to have your participation, so I will show the case, and I will ask your opinion, whether this case is asthma or COPD. So be prepared for that. We have the 69-year-old male, heavy smoker, dyspnea, cough with sputum or wheezing. We will take a look at that. FVC. How about that? Dr. Luyện, could you please join us? Please have a mic.
Test.
Yeah. Dr. Luyện. Yeah. Thank you for participation.
Okay, for this patient, we have FVC pre-bronchodilator with this score negative 1.62, so is normal.
Normal.
Yeah.
No restriction. Yes.
Yeah, no restriction. And we have ratio FEV1, SVC also. FEV1, FVC is lower than the LLN.
Yeah.
Yes. And we...
So we have?
Obstruction.
Obstruction.
Yeah.
And the severity?
FEV1 47%.
No, it is a -3 or 6.
Yeah.
So we have a more moderate.
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 Yeah.
Obstruction.
Yeah.
Yes.
And post bronchodilators, we have ratio FEV1, FVC, also FEV1, SVC, also lower than lower than the LLN.
Yeah.
That's so this patient still have obstruction.
Yeah.
Yeah.
So look at the bronchodilator test.
Yes, but we have FVCs increased to 87%.
Electricity?
FEV1 shows 59%.
Yeah. And 2 minus?
Yeah.
I think that it is darker. No, there is still, you have to plug in. That's is that electricity is normal? Yeah, thank you. Yeah, so please take a look at the bronchodilator test.
Yes,
is it positive?
Yeah.
Yeah?
Positive?
Positive, bronchodilator test.
Yeah.
And this one?
Yeah, this one, FEV1 also positive.
It's also?
Yeah.
Yeah. So?
But and you can see the curve of pressure and volume shows maybe these patients have obstructive, still have obstructive, and this patient maybe have, I think this patient should be the
COPD.
Yeah.
Yeah. But we will go next to see at the result.
Spirometry.
No, we took at the box.
Yeah.
The box here.
Yeah.
TLC.
Normal.
Normal.
Yeah. Yes. But we can see the RV and ratio of RV over TLC's spheres higher.
The air trapping.
Yes. Air trapping.
Air trapping.
Yes. These patients have air trapping, so this patient, I think, diagnosed COPD.
Yeah. And then we will go to the DLCO.
Yeah, DLCO with
PCO, VA. All of them are
normal.
Are normal.
Yeah.
So, COPD or asthma?
Normal. But normal. Yeah.
I just have a discussion.
Maybe.
The patient responding positive to the bronchoprovocation.
Yes.
Yes, correct. So that would determine asthma.
Yeah.
Correct.
But after the bronchodilator test, they still have obstruction.
Yeah.
They still have obstruction. So by the definition of the goal, it is a COPD. If you still have obstruction post bronchodilator test, you have a COPD. I just have a discussion with Dr. Thi this morning, because when I see that positive bronchodilator test and then normal DLCO, I think that it could be asthma. But the goal do not mention about DLCO in definition of COPD. So that if we adhere to the COPD definition of goal, it is COPD. And about 1/3 of COPD patients, they have positive bronchodilator test. Yeah. So the conclusion of this patient is he has COPD. He has COPD. But with normal DLCO, I think that the prognosis of this patient is very good. It's better than the other one with low DLCO. Yeah. Thank you, Dr. Luen, so much.
Yeah,
is there anybody who would like to join for the second case? Yeah, I will invite you. Are you ready? Yeah, so please. It is a 54 years old male. He has history of asthma. He has a dyspnea, cough with sputum, and wheezing. So please ask this lady. Yeah. So please try. This lady. We will work together. Yeah. To take a look at the FVC. How about that? Normal. Yes. There is no restriction. No restriction. No restriction.
No.
No restriction. And how about the ratio?
The ratio, FAV1 and per FVC lower than lower than LLN.
Lower limit of normal. Yes. There is obstruction.
Yes.
Obstruction. And how about the severity?
FAV1 mild.
No, it is moderate.
Moderate.
Yeah, moderate. Less than 2.5. It is moderate. Yes.
Yes.
Yeah. And after the test, is there still obstruction?
Yes.
Yes, still have. 54 in comparison with 72.
Yes.
Yeah. And how about the bronchodilator test? We have here was 93 minus. So it is a negative. Negative.
Yes.
Negative. And for FEV1, it's only 3. Yeah, the requirement is a 10. You catch it? That you have to take the breath of the post-bronchodilator test minus the pre. If it is bigger than 10, then we have a positive bronchodilator test. Yes? Yeah. So in summary, there is a patient with no obstruction, no restriction, with moderate obstruction, and negative bronchodilator test. Yeah. So could you decide right now? COPD or asthma?
COPD.
Yeah, it is already clear that obstruction, even post-bronchodilator test, and negative bronchodilator test. But anyway, we will see. How do you interpret that? TLC. The green is a normal one.
Yes.
If you do not remember that the word 1.65, so it is a normal one. So there is a no restriction. No restriction. No restriction. Normal lung volume. Yeah. And there is also no air trapping. No air trapping. And about DLCO, it's so big, DLCO, key CO, and normal VA. So how do you think, Dr. Tuyet, asthma or COPD?
With these patients, also patients have obstructive on spirometry, but on plethysmography show the normal TLCs and he don't have air trappings, and on the DLCO is so normal. So this patient I also with a negative post-bronchodilator, but maybe he affects maybe the technique on during on the spirometry. So this patient, I think that's the diagnosed asthma.
Yes, yes. It is asthma with fixed airway obstruction. Asthma with fixed airway obstruction.
Yeah.
Because if we look at the interpretation of the DLCO, we will see that abnormally high.
Yeah.
So he has asthma. So I think so. It's so important. Go to the box, please. Go to the box.
Yes.
Not stop at the not stop only at the spirometric test, because we will decide she has asthma, she has a COPD, and then he has COPD, and treat them as a COPD. But in reality, he has a fixed airway obstruction of asthma with fixed airway obstruction. So the differentiate diagnosis is so difficult. So we have another one. No. Yes, 63 years old male, also heavy smoking, pleural effusion in the history because of tuberculosis. Anyone to join? Would you like to join with us? Yeah? So please try. We will help. Yes. This is still not to have yet score in that way. Use it. Yeah. How about the VC and FVC?
Here we have the VC and FVC is normal.
Yes, a green one is a normal one.
Yeah.
So there is no.
And so
No.
it's no restriction.
No restriction. Yes, no restriction.
But
And how about the ratio?
the
Which
ratio
one will you use? 46 or 45?
is in comparison with the score is the severe.
No, not severe. Just at that stage, we just say that obstruction or not.
Yes, we have obstruction.
Yeah. I remind you that between those ratio, we will use the less one. The less one. Yeah. 45. In compare with the 69, so that there is obstruction.
Yes.
And how about the severity of obstruction?
The severity was severe.
Minus
The -4.
-9. So it is,
It is moderate.
yes, moderate. And how about the post-test? Post-test, still obstruction?
Still have.
Still obstruction. And how about the bronchodilator test? We will take the 49 post minus pre.
Negative.
Yeah, negative. So, no restriction, moderate obstruction, negative bronchodilator test.
Yeah.
Yeah.
And then
Could you decide right at this stage, asthma or COPD?
could be a COPD.
Could be COPD. What is the next step?
Well, we check the TLC.
Yes, go to the box. Go to the box. For the TLC, we have the same, no restriction.
Yeah.
No restriction. And what does it mean here?
The RV was
What?
RV was moderate.
What do you have here?
It's high RV. It means that
There is air trapping.
yeah,
Air trapping. I love the word air trapping because the hyperinflation, once you have the big TLC,
Yeah.
so
trapping.
air trapping. Air trapping.
Yeah.
And how about the DLCO?
DLCO.
DLCO with hemoglobin
There.
is here.
DLCO, we have
Low
low.
DLCO.
Yeah.
How about the KCO?
KCO was normal.
Normal. How about the VA?
Was normal.
Normal. So we just take a look. We have a low DLCO,
Yeah. Low.
normal VA,
Normal.
normal VA, yeah.
Normal VA.
So
Normal.
we have here
Could be
new things:
anemia.
pulmonary vascular abnormality, pulmonary hypertension, or pulmonary embolism, or vasculitis, or emphysema with preserved lung volume, or early ILD, or anemia.
Yeah.
So which one will you choose?
We reverse with the the past medical history of this patient. One male, 64, with history of smoking, pleural effusion. So I think we should be do the another test, like the echocardio.
Mm-hmm.
To find the to do the belong about the heart.
Mm-hmm.
And it could we do also the MRI to think about the pulmonary embolism.
Mm-hmm.
So I think we also do the cardio echography, do the MRI, and also do the blood test.
Yeah. But right now, the patient has no symptoms of pulmonary embolism. So I think that at that stage, we could stop at this one, emphysema with preserved lung volume, because he is a smoker, heavy smoker, and he also has air trapping. Yeah. So it is COPD with early emphysema. Yeah.
Yes.
So it is a great. So I think that I always have two copy of this diagram to take with me to interpret.
Yeah.
So I think that we all agree that to obtain a solid asthma or COPD plus asthma diagnosis, we have to have a detailed history, a spirometric test, but using new standards of ATS in ERS 2021. I think that if you have own spirometer, you have to change. The new one, we have the GLI, we have the Z-score. So please use it with the Southeast Asian reference. And plethysmography is essential. If you have a typical asthma, you can stop there. But with COPD, you have to go out because there will be very difficult to differentiate between fixed airway obstruction in asthma with fixed airway obstruction, or COPD. And the differential diagnosis between those two diseases is very, very important because it related to your kind of treatment and the prognosis of the patients. So, and also avoiding the risk of missing COPD, I did not show too, but there is some case, because of airway obstruction, you will have the low FVC on COPD patient. And if you have a low FVC, you will have a high ratio. So you will have a case with restriction and no obstruction. Yes? But when you use the box, you will see the reverse one. There will be no restriction but obstruction. So the missing diagnosis of COPD is also a very important one. And differentiating asthma with fixed airway obstruction from COPD and also early emphysema need the box. So thank you so much for your cooperation and attention. Thank you.